Similarly, I also come across people who ask me, what is the basic difference between a gastric bypass, which is done by many people, which is a classical Roux-en-Y gastric bypass, and an MGB or a mini gastric bypass? Here I would want to clarify just a few things, that how a classical Roux-en-Y gastric bypass is different from a mini gastric bypass. And just because it is called mini gastric bypass, it doesn't mean it's anyway a smaller surgery or a simpler surgery, or it has less amount of effects, right? In a classical Roux-en-Y gastric bypass, what we do is we connect the intestines in such a pattern, thereby making a roux limb, so that the food which is from the stomach will go in another limb or another channel and will come to the intestine. And the bile and the pancreatic juice from the other channel, and they will mix somewhere close to 1 to 1.5 meter down the intestine. So the bile cannot go up. The bile will flow down, the food will go down, and everything goes down. In a mini gastric bypass, what is so different? Instead of making two anastomosis or two joinings or two joints, we make just one joint. So it is also fair to call it a one anastomosis gastric bypass. It's also fair to call it a omega loop bypass. It's also fair to call it a Billroth 2 gastric bypass. What do we do? Instead of making a small stomach pouch the way we classically do in a Roux-en-Y gastric bypass, we make a long tubular pouch or a long tubular sleeve. So we make a very long and a tubular sleeve as a pouch. Take intestines anything between 200 to 300 centimeters and do a gastrojejunostomy, that is, make a anastomosis or joining between this long cylindrical stomach sleeve with the intestine. Thereby, the food directly goes in there into the intestine, and the bile and the pancreatic juice will take a long circulation and will join the food here. The opponents of this surgery would say the bile can actually go up. Yes, it may, but to what level? It cannot go to the esophagus because the tube or the sleeve that we make is a very long and a tubular one. So in my series, in a large number of series by so many people around the world, and I would want to tell you here about 10 to 15% of all gastric bypass done in the Europe are mini gastric bypass, right? So we haven't really seen, when we do endoscopies, too much of reflux or biliary reflux. I haven't as yet operated any patient on which I had to undo for biliary reflux. So it's a good procedure. The advantages over a classical Roux-en-Y gastric bypass is there's only one anastomosis. So theoretically, there are less chances of this getting obstructed. So chances of intestinal obstruction, which are close to 0.5 to 1% or even 2 in some series in a classical Roux-en-Y gastric bypass, are close to 0 in a mini gastric bypass. And also there is one anastomosis, so technically it would be, I would say, slightly easier than doing a classical Roux-en-Y gastric bypass. And there are no mesenteric defects. So the chances of internal herniations which are there in a Roux-en-Y classical bypass, if you do not close all the intestinal and the mesenteric defects that you close, would be much less or actually negligible in a mini gastric bypass. So essentially both work similarly, whereby in a mini gastric bypass is of more malabsorptive, a classical Roux-en-Y is more restrictive and malabsorptive, but the effects of both are almost similar after 5 years and 10 years in a patient who gets an MGB or an RYGB.